Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. My name is Dawn Liz Powell, Medical Editor at MIMS Learning, and here with me is our editor, Pat Anderson.
Hello.
So today we will be talking about diabetic kidney disease, and I am not kidneying around.
I do have to groan at that one. You say my puns are bad. Perhaps even AI could come up with something better than that.
Actually, it couldn't. I asked AI to come up with a joke about the kidneys, and it told me that the kidney crossed the road because it wanted to get to the other ureter. Even Christmas cracker jokes aren't that bad.
No, they're not.
But bad puns aside, back to the point. Diabetic kidney disease can have a major impact on both mortality and morbidity. Right, so diabetic kidney disease. To briefly go over the stats, we know that lots of people in the UK have diabetes, nearly 5 million in fact, and the vast majority of these will have type 2 diabetes. A substantial number, about 40%, will go on to develop chronic kidney disease or CKD, making diabetes the leading cause of kidney failure globally. As you might expect, people with both diabetes and CKD are at high risk for both cardiovascular and renal complications.
And I guess as listeners will know, the consequences of these complications can be severe. So let's just go over what we mean by diabetes-related kidney disease. We have a 3-part series on diabetic kidney disease on MIMS Learning by Dr. Andrew Frankel. In the first module of this series on diagnosis, he notes that the term diabetic nephropathy was historically used to describe kidney disease that developed as a complication of diabetes. However, he says that diabetic kidney disease is a more useful term because it can refer to both kidney disease that occurs as a complication of type 2 diabetes and kidney disease that coincides with type 2 diabetes. That is, kidney disease that is not directly caused by the diabetes.
Okay, moving on. Should we talk about diagnosis? Dr. Frankel states that the first observed abnormality is often subtle changes in blood pressure with loss of the nocturnal dip and then a gradual rise in blood pressure generally. He adds that abnormalities of albuminuria develop from an early stage of the condition and gradually increase in a progressive manner. This is referred to as going from normo and micro to macro albuminuria, but should be seen as a continuum. These changes are often identified in association with changes in GFR, and if observed early enough, there can be an initial period of hyperfiltration, GFR in excess of normal levels, followed by a slow decline in kidney function.
To add to that, the final stage of diabetic kidney disease is usually in association with significant albuminuria and hypertension as the person progresses towards end-stage kidney disease. However, patients can have significant disease without proteinuria or with very low levels of proteinuria. Going back to CKD that's not directly caused by diabetes, Dr. Frankel states that a non-diabetes cause of kidney disease should be considered if there's no retinopathy, if hypertension has not responded to optimal therapy with 4 or more agents, if the patient previously had normal ACR but has now rapidly developed heavy proteinuria, or if they've had an accelerated decline in eGFR. The patient being systemically unwell is another sign the cause might not be diabetes. And if a healthcare professional does suspect that the cause is not diabetes, Dr. Frankel advises they should undertake appropriate further investigation or referral, and he notes that ruling out obstruction with ultrasound is important.
I mean, as I was sort of mentioning before, having both CKD and diabetes is not good news. So essentially, the mortality risk in people with type 2 diabetes and CKD is greater than either those with type 2 diabetes alone or those with CKD alone.
So we're talking here about diabetes and CKD, but there's also a wider angle, isn't there? I know there's been a lot of discussion at the moment about cardio-renal-metabolic disease, or CVRM, at the moment. And as far as I understand it, CVRM refers to the overlapping of diabetes, kidney disease and heart disease. Is that correct, Dawn?
Yeah, I write news stories for our sister website, MIMS, and we see lots of stuff on CVRM there.
Oh, that's interesting. And on MIMS Learning, we have another module on polypharmacy in CVRM disease. And in that, a study is mentioned. And this study shows that 25 to 40% of patients with heart failure have diabetes, 40 to 50% of patients with heart failure have CKD, and as you mentioned, Dawn, 40% of people with diabetes will develop CKD. Additionally, 16% of patients with heart failure also have both diabetes and chronic kidney disease, and the combination of these three comorbidities is associated with substantially increased risk of hospitalisation and mortality.
From what I understand, a key concern is that the three conditions are often treated separately. For example, the cardiology team looks after the heart failure, the diabetes team looks after the diabetes, and the kidney team looks after the CKD. However, in an ideal world, it would be better to have one specialist or one team looking after all three conditions. While, spoiler alert, we do have a module coming up on CVRM disease, we don't have huge amounts of information on managing it as a collective entity. So for the time being, let's stick to diabetic kidney disease. Fortunately, there's a fair bit of information on that, so lots to discuss.
Absolutely. So ideally, you want to prevent someone with diabetes getting chronic kidney disease or anything else in the first place. And Dr. Frankel, in his 3-part series, states that all newly diagnosed people with diabetes should be advised about the risk of cardiac and kidney complications and how they can prevent them. For example, by following dietary recommendations and aiming to achieve good glycaemic control, particularly in the first few years after diagnosis. The next step is to identify kidney disease in people with diabetes, and Dr. Frankel observes that healthcare professionals should consider reviewing all patients with previously diagnosed diabetes to see if they've had EGFR or ACR testing.
Okay, so following on from that, if a person does have both diabetes and CKD, according to Dr. Frankel, there are 5 steps to optimising management.
5 steps, okay. I thought there were maybe 4, but has something changed?
Well, yeah, the advent of SGLT2 inhibitors. So previously, you would add in an ACE inhibitor or an ARB, then you would try to manage blood pressure, which of course could also include giving an ACE inhibitor or an ARB, reduce risk factors for cardiovascular disease such as lipids, and optimise the diabetes management with oral hypoglycemics. But now there's another step, adding in an SGLT2 inhibitor. The NICE type 2 diabetes guidelines say that a SGLT2 inhibitor should be offered to people with type 2 diabetes with CKD if they are already on an ACE inhibitor or ARB and have an ACR of more than 30 milligrams per millimole.
So can any SGLT2 inhibitor be used?
Well, dapagliflozin and empagliflozin are the only ones with indications for CKD with or without diabetes, and they are both recommended by NICE. Dr. Frankel states that the glycaemic benefits of SGLT2 inhibitors do go down as kidney function goes down. However, he adds the benefits in relation to the kidney protection and reduction in hospitalisation for heart failure continue. That, of course, no drug is without side effects or risks. And Dr. Frankel notes there are issues to consider with SGLT2 inhibitors, such as diabetic ketoacidosis. Before starting a person with diabetes on an SGLT2 inhibitor, prescribers should consider several factors. For example, do they have a history of ketoacidosis? And have they been provided with good sick day guidance? He adds that the NICE guidelines on CKD do have more information on when GPs should consider referring to a specialist if kidney function is continuing to decline.
So what about GLP-1 agonists? They're in the news, hardly ever out of the news. And like SGLT2s, they are diabetes drugs that seem to have multiple indications.
Well, yes, some GLP-1 agonists are safe to use in people with CKD, including those with very limited kidney function. Of course, the GLP-1 agonist semaglutide is indicated for people with obesity, whether or not they have diabetes, and it's also indicated for people who are overweight with additional risk factors for cardiovascular disease. While there is evidence that it can reduce the risk of death in people with both CKD and type 2 diabetes, at present it doesn't have a specific indication for CKD, nor is it recommended by NICE in this context.
That's interesting, although I guess it's possible recommendations could change. As you say, The GLP-1 agonists and the SGLT2 inhibitors are established drugs for diabetes. So a person with diabetes and CKD may well be on one or both of these drugs anyway to achieve the diabetes control that you were talking about earlier, Dawn. I'm just going to mention the targets for HbA1c in people with CKD, as these do differ depending on the stage. Dr. Frankel provides details of exactly what these are in his learning materials, but in essence, the targets become less strict as CKD progresses. Also, we should mention the other drugs that can be used for glycaemic control in people with diabetes. These include metformin, which of course is the first-line drug for type 2 diabetes, sulfonylureas, and DPP4 inhibitors. Do have a look at the third module by Dr. Frankel on therapy options, as that has comprehensive information on which drugs in these classes can and can't be used in people with diabetes and CKD, including which ones increase the risk of hypoglycemia in people with CKD.
Yeah, and the modules are collectively worth a suggested 5 CPD hours, so very comprehensive and lots of learning. We've already mentioned MIMS, our sister website, but as a reminder, it has a comprehensive database of drugs available for prescribing and has several tables on the drugs available for certain conditions.
That's brilliant. And can I just mention as well that if you subscribe to MIMS Learning, that actually gives you full access to MIMS now.
Well, that's really good to know. But back to the topic in hand. You were mentioning glycemic targets there, Pat, but I think we should mention lipid targets as well. So, as discussed, one of the steps for optimising management in people with diabetic kidney disease is reducing the risk of cardiovascular disease by addressing cholesterol and other factors. The module we have on the NICE guidelines for cardiovascular risk reduction specifies that atorvastatin 20 milligrams should be offered for primary prevention and atorvastatin 80 milligrams should be offered for secondary prevention. However, in people with CKD, for both primary and secondary prevention, atorvastatin 20 milligrams should be offered. If lipid targets are not met, dose increases can be considered up to a certain point, but in people with very reduced kidney function, dose increases should be agreed with a renal specialist. According to NICE, this is because renal impairment is a risk factor for certain adverse effects of statins. I think that's everything we can cover today. Thanks so much for discussing this with me today, Pat.
You're welcome, and thank you very much for the bad pun earlier. I do love a bad pun.
Yeah, I'm kind of regretting that now because I think it's only encouraged you. Right, so what are our takeaways today? Lots of people in the UK have diabetes, and the vast majority of these will have type 2 diabetes. A substantial number will go on to develop CKD, making diabetes a leading cause of kidney failure globally. People with both diabetes and CKD are at high risk of cardiovascular and renal complications. The 5 steps to optimising management in people with diabetic kidney disease are ACE inhibitors or ARBs, blood pressure management, use of SGLT2 inhibitors, cardiovascular risk factor management and glycaemic control. And in people with CKD with high cholesterol, for both primary and secondary prevention, atorvastatin 20 milligrams should be offered. If lipid targets are not met, dose increases can be considered up to a certain point. But in people with very reduced kidney function, dose increases should be agreed with a renal specialist. Thank you very much for joining us today. Don't forget that you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Look out for our next episode where our colleague Sankita Krishnan will be speaking to Dr. Cara Bosley about asthma in children.